Dr. Miller, good to see you. Representing PHM. Well, thank you all for joining us in person and virtually. I am delighted to introduce a spectacular colleague and friend, Flor Munoz. Dr. Munoz attended medical school at Universidad Francisco Marroquín in Guatemala, and then came to Baylor College of Medicine and Texas Children's Hospital, where she did residency, Peds ID fellowship, and then rose through the faculty ranks. And she's now, as you see, an associate professor of pediatrics and molecular virology and microbiology in the Baylor College of Medicine. And she's medical director of transplant ID at Texas Children's Hospital. Dr. Munoz is a physician scientist, and her work has focused mainly on the epidemiology and treatment of infectious diseases, and particularly vaccine effectiveness and safety in special populations, predominantly pregnant women, young infants and children, and immunocompromised hosts. She's been as investigator in the NIH-funded Vaccine Treatment and Evaluation Unit at Baylor. She's been PI or co-investigator on more than 20 vaccine trials for Zika, SARS-CoV-2, influenza, pertussis, RSV, et cetera. So many of you watching don't know this, but a lot of the vaccines that our patients get do so from trials run and contributed to by Dr. Munoz. She's published over 200 research articles on various topics. She's been remarkably productive in multiple arenas, many on vaccine effectiveness and safety. They've been in terrific journals, the American Journal of Transplant, Clinical Infectious Diseases, Journal of Infectious Diseases, JAMA, Lancet, multiple New England Journal of Medicine papers, including a beautiful first author paper on the SARS-CoV-2 mRNA vaccine in kids under 5. So remember when we all started giving the COVID vaccine to kids under 5? You can thank Dr. Munoz after her talk. And her work has been funded by NIH, CDC, and the Gates Foundation. Flor has also done a lot of service. She's served at the AAP, both the Committee on Infectious Diseases and in the Section for Infectious Diseases. Because of her work in maternal vaccination, she's served with the American College of Obstetrics and Gynecologists Maternal Vaccination Group and on the CD-ACIP. The ACIP is who decides how to implement vaccines once they're licensed. FDA just says it's licensed, you can use it. The ACIP is who tells us here's how you should use it and for what populations. And she's contributed many other service activities and is a member of many professional committees. And then finally, Flor does very broad teaching. She teaches on vaccinology at the Institut Pasteur in Paris and the International Vaccine Institute in South Korea and at Universidad de Chile, and today here in Pittsburgh. So please join me in welcoming Flor Munoz.
Well, thank you so much for that very generous introduction and all of the timeline. It's getting tired just to hear, but no, it is really my pleasure and honor to be here with you this morning. I very much appreciate the invitation. First time in Pittsburgh, first time at this children's hospital, but I'm very much looking forward to visit more when I return. I'm also part of the NVSN, the New Vaccine Surveillance Network that you are part of. And so we'll talk actually a little bit about that along the way. And I actually wanted to tell you a little bit of where we are and how we got here in terms of maternal immunization for a method of prevention of RSV. But of course, this has been a big topic of discussion and a lot of novelties this year. So probably you've heard some of this, but I wanted to give you a little bit more personal perspective from this. So as Dr. Williams has said, I'm actually involved in a number of activities, including being a member of safety monitoring committees. And so that's one of my disclosures. And what we will do today is a brief review of the epidemiology, why babies get particularly sick with RSV, and talk about these options. And again, I'll walk you a little bit through the history of that and see where we stand and what the future challenges will be. So some of you have seen this. One of the big updates regarding epidemiology of RSV is the availability of a couple of networks that are very important that I would encourage you to utilize. One is the RSV Net that looks mostly at hospitalizations, and the other is the NERVS, the National Respiratory and Enteric Virus Surveillance System, which has been in place for a long time and follows positivity or positive PCR testing in the country. And this is contributed by many laboratories. So here is just to show you how our most recent 2023-24 season was actually still a very active season in terms of severity of disease, hospitalizations, not as bad as the comeback after the pandemic, which we all remember very acutely, but certainly much higher in terms of activity compared to the pre-pandemic period. And there's no question that RSV is a very important problem in pediatrics. But if you play a little bit with the RSV Net tool, you see that you can actually do a lot of interesting things. Interested in pediatrics, I wanted to see the hospitalization rates by age. And here is the key point. This is December, which was the peak of activity of 2023-24 season. And you look at hospitalization rates in the overall population was 47 per 100,000, but in the babies under 6 months, which is our highest concern group, it was very high, 471 per 100,000. Even in the second half of the first year of life, 6 months to 12 months, you see that it's about half of that, and the other children 1 to 4 years is below that as well. So there's no question that we do have a significant overrepresentation in the first few months of life, and that if you look at some of the CDC data, you see that the majority of this, a lot of it is going to be also reflected in our clinic visits, outpatient visits. Mortality in the US, fortunately, is not very high, but it is still an important cause, RSV, of mortality compared to flu, for example, in the first 6 months of life. It is higher. Globally, mortality from RSV is quite significant, and it's been estimated to cause about 2% of the deaths in the under 5-year-olds and about 3.2% of the deaths in under 6-month-olds. So this is just to put things in perspective. NVSN, the new vaccine surveillance network, has contributed to data. This is data right before the pandemic. But I just want to make here clear the point that even within those 6 months of risk, first 6 months of life, the first 3 months are critical. So here you have data from 2000 to 2005, which is in red. Those data from Carolyn Hall, who had looked at information about the distribution of the cases and noted that about 50% of the disease in the first year of life actually happens in the first 3 months, and especially in the neonatal period. And then data from the NVSN confirmed that, the yellow bars, where the distribution is basically the same. I don't think we necessarily have a huge number of cases before the pandemic, but we do have a better detection. So these are some data that reflect more of the reality of what we're seeing. And another paper that I wanted to share with you regarding the epidemiology is the point this paper that makes the point that healthy infants, not just preemies, are going to be probably the highest risk population. This is from the NVSN network from 2015 to 2016. And I just wanted to share this because it has been a topic of discussion, even with the intervention with palivizumab. As you know, we focus on, before the vaccines became available, immunization through passive immunity became available with other methods. We focus on the less than 29 weekers, and certainly, they are at risk. There's no question about that. But if you look at by gestational age at birth and when the RSV hospitalizations occur at all ages, but especially in the first 2 months of life, it's going to be the full-term babies. Preterm babies, it's actually happening a little bit later. And it makes sense, right? Because a lot of these very young preemies are staying in the NICU and they don't get exposed until they go out and then in the community and see maybe those are getting infected a little bit later. So an important contribution, I think, this paper, because it tells us about the burden in term infants, and also 67% of those term infants did not have any pre-existing comorbidity or preterm birth. So these are healthy infants. It makes the point of the need to really have an intervention that protects the majority, all the babies. So we also know that babies are at risk because of their anatomy. They have smaller lungs, they have smaller airways, they have a lot of inflammation with RSV. They are nose breathers and their nose gets obstructed, and they have a lot of plugging in their airways. So that's one reason. But there's also nice work that has been published by some colleagues, including Octavio Ramilo and Asun Mejias, and from Nationwide and now St. Jude's, that have shown that intrinsically infants less than 6 months of age might not have the ability to really produce the proper immune and inflammatory response to fight some of these viral infections. So here's just one paper where they have seen that in terms of mucosal immunity, having higher concentrations of certain mucosal interference results in protection. And that doesn't happen until a little bit later, so 6 months of age and older. And in terms of those babies that have these interference, they can avoid the risk of hospitalization. So there are many reasons why babies are at risk. So with that, let me just jump to this very landmark year. Here we are in 2023, and it is really remarkable, as you'll see, that for the first time, and at the same time, we have a first long-acting monoclonal antibody that is recommended indeed for all infants at birth and up to certain years of age. So you know, up to 2 years in the high risk and up to 8 months for the otherwise healthy children. And then we have for the first time a passive prevention through maternal immunization, which is a vaccine that we were able to start using according to recommendations as of last fall. So I'll take you back a little bit because I do want to start with the fact that a lot of people feel that this is very new, but there have actually been decades of work on this. And I will mention briefly Dr. Robert Chanuk's work. You know, some of you are familiar with that, where he described in 1957 what we now know as RSV, and this was known as the chimpanzee coryza agent, and it was isolated during an outbreak of a respiratory illness in children. And I think what's interesting is that, of course, in addition to identifying this chimpanzee coryza agent as RSV and describing its syncytia formation in the cytopathic effect, he also demonstrated that children had neutralizing antibodies even very early on in the first few months of life, and that actually dropped over time and increased later. So this was an indication that there was immunity already transferred passively from the mother to the baby, and these babies had some immunity, but not necessarily protective immunity. Another landmark study was the Houston family study. This is why I ended up working on RSV and maternal immunization, because Paul Gleason, who's in this photo, and the team here really were among the first who described how children develop immunity to RSV. And this was very simple. You know, again, they already had a virus identified. There was knowledge about the F and the G glycoproteins in the surface of the virus and the fact that these were targets to antibody. And here they just demonstrated that having antibodies specifically to the F protein resulted in a protection against lower respiratory tract disease. So that in a small number of children, this is either through passive immunity from the mother or from prior infection, those who had higher titers specifically to the F protein had milder illness, so upper respiratory illness, as opposed to LRI. So this was known, and the goal there was then to have something, a vaccine that would produce increased antibodies to the F protein. These were some of the considerations at the time. And again, this is already known that the most serious disease occurs in the first 3 months. Babies already have some antibody at that time, maternal antibody, but even that antibody might not be fully protective. So if we wanted to boost that immunity, we needed to do it as soon as possible after birth, okay? And that we don't have a particular threshold, so we still don't know as of today what that immune correlate is, but higher antibody titers correlated with either a delay onset of RSV, as we saw in the Houston family study, or a less severe illness, as well as seen as the Houston family study and others. So the goal of immunizing children, which was initially the point, was to really try to decrease or delay the severe disease, specifically symptomatic lower respiratory tract illness, which then could result in prevention of hospitalization, mortality, and so on. And we know now, of course, there is an interaction between bacterial pathogens, specifically pneumococcus and RSV and other viruses, that you could also decrease all-cause pneumonia. You could decrease antibiotic use for those of you who work on that. And you could also decrease long-term consequences like RAD and asthma. So the initial point was to develop vaccines for children. And I have to mention the event with the formalin inactivated vaccine, because this was a way to prepare vaccines, using the full virus inactivated in a relative crude way compared to current methods, with formalin. And then there were several vaccines that were prepared at that time, actually in the 1960s. And these are results from a US experience. A similar experience, a similar vaccine was used in Europe, in Germany, but this did not happen to them, which is the known vaccine-associated enhanced disease. This is not antibody-mediated like dengue, but it's a different mechanism. And in this case, you see 4 clinical trials here that reported that after vaccinating a group versus a group that was not vaccinated, there were more cases of pneumonia or hospitalization in the vaccinated group. And that was quite significant. Actually, in one study here by Kim, a couple of children died from their RSV infection, even if they had been vaccinated earlier on. So it was not that the vaccine had an adverse effect. The vaccine was not the cause of the problem, but it was not an immunogenic, a protective enough vaccine, and the children still got RSV, and some of them, again, as you see, had enhanced disease, so worse outcomes compared to those who were not vaccinated. This was this one particular lot and these particular studies, but it was sufficient to be concerned about this process. And what we know, these are some of the theories about why this happened, is that, again, probably there was not sufficient neutralizing activity from those antibodies. So this is an example of a couple of studies that looked at natural infection versus vaccination. And you see that you can measure before and after infection and before and after vaccination binding antibodies, so IgG. But in the case of these formalin inactivated vaccine, the neutralizing activity was not the same as after a natural infection. So poorly neutralizing antibodies was potentially the reason why this enhanced disease occurred. Obviously, this marked the development of any vaccine for children because any vaccine needed to be tested for the potential of developing enhanced disease. So there was another generation of vaccines for children that came along, and that was the PFP, or purified fusion protein vaccines. There were several generations of these. You see some were adjuvanted. And they were tested in adults, and the age de-escalation was such that, again, some seropositive children all the way down to about 18 months of age were tested, and also children with CF. And although this vaccine, again, produced antibodies, it was not making enough neutralizing antibodies. It lost potency. Nevertheless, these studies show that no enhanced disease occurred, which was interesting because, again, that was a pretty unique phenomenon with that vaccine. So that this vaccine did not pursue any additional development. And then lastly, in terms of other attempts to vaccinate children, there's been the live vaccines, right? So this is an important concept. We have done it with influenza, and there's been attempts to do it even with current viruses. I think it's a good way to have local immunity. Here, the challenge is that although we do have a mechanism by which we can study these, again, with age de-escalation, there is an important balance that needs to be found, which is balance between the local reactogenicity from having a respiratory virus replicating in the nose and causing inflammation and, again, obstruction of the airway, and the right immunogenicity, so enough protection locally and potentially systemically that you can protect the infants. So these are cold passage temperature sensitive vaccines that only replicate in the nose, but they continue to be evaluated because of that balance that needs to occur. So these vaccines also should not be associated with enhanced disease. They haven't been, as they've been tested. A number of trials have occurred. And I want to show you just briefly that there is still work happening in terms of developing vaccines for children. So there are at least 2 live attenuated vaccines, one from NIH, one from a company called Mesa Vaccine, that have done phase 2 clinical trials and have shown that these vaccines are immunogenic and that at different dosages, they have been safe and well tolerated. So these are being pursued. And then with more recent technology, because I think that as you'll see, the identification of the pre and the post fusion conformations of the F protein have really allowed us to be more specific. And probably what happened with the formalin inactivated is that it was not the pre-fusion conformation that was being targeted. So the antibodies were not neutralizing, but new technology like recombinant viral vector, F protein, protein-based vaccines like the ones we have right now, and mRNA, have actually been looked at to start doing studies in infants and children as well. So potentially we could have an infant vaccine coming up in the future. Now, going back to what we have been doing before we have infant vaccines, briefly to just talk about the passive antibodies. So again, the concept of passive immunity had been there from day one, and it should work no matter how we get it, either given the passive immunity to the baby or through maternal vaccination. But in the 90s, we started using high titer polyclonal immunoglobulin, just RSVIG, and that was promptly actually replaced with the use of palivizumab, which was, again, a specific humanized monoclonal IgG that was directed against the F protein, and that could be protective given about once a month because it has a shorter half-life than the current monoclonals. But because of cost and because of logistics and so on, it was really recommended for the highest risk group, the less than 29 weeks, which is a small proportion of the population. So from a long time, as you can see, there were attempts to actually have a monoclonal antibody that had a longer activity, a longer half-life. And just to briefly mention too, modavizumab was also humanized IgG that was modified so that it had a half-life of about 60 to 80 days. And it was great in terms of neutralizing activity, a lot more potent than palivizumab, but it had some toxicity issues, and the trials resulted in rashes and an unacceptable reactogenicity that resulted in its being stopped and not continued. The second one was subtavimab. We actually did these trials as well in Houston. This is also long-acting, but the problem with this one is that it didn't work. And here I try to show you the overall results. These are a placebo is in green, and the 2 dosages of subtavimab were tested here. And this is a cumulative incidence of RSV hospitalizations or outpatient LRTI. And you see that there's no difference. And there's no difference because mostly of RSVB. Here, actually, you had fewer cases in the vaccinated immunized children, with subtavimab compared to placebo for RSVA. But in the RSVB, it was the opposite. So what happened is that during the time of that phase 3 clinical trial, there was a new variant of RSVB that had mutated enough that it rendered the monoclonal antibody ineffective. Similar to COVID, we learned about that in COVID. So I'll just say that there's always a potential risk that this could happen, but it's thought to be much less with the current monoclonal antibodies because the variability of RSV obviously is much less than COVID and then flu. And although there are different genotypes out there of the full virus and also the F protein, you do have a relatively more stable activity. So it's going to be something to watch. And I'll just say a couple more words of monoclonals before I jump into maternal, because we have to mention these. Nirsevimab, which is the monoclonal we have now approved, had 3 important clinical trials. They looked at the preterms that were not needing synergists, so 29 to 35 weekers. They looked at the preterms in children with chronic lung and heart disease that would be needing synergists. So there was the control here was the palivizumab. And then they looked at the late preterm and term infants. And you see that in terms of the efficacy endpoints, looking at lower respiratory tract illness that was medically attended, which is here highlighted, it was about 70 to 80% in the clinical trials. And looking at hospitalization similarly in the 70s to 80%. So this was very promising, and from even the clinical trials, because it was a long-acting with a half-life of 70 to 85 days and protection up to 150 days in the clinical trials. I'll point out that if you look at specifically the study in the late preterm and term infants, you see how a lot of that protection is based on the first 90 days after administration. So I think this is critical, because when we're looking at comparing maternal vaccination, which is babies born already with antibodies at birth, versus nirsevimab, you do want to look at nirsevimab given at birth to really have a fair comparison, right? Because this decay of antibody, this drop in efficacy is also associated with a decay in antibody, even with a longer half-life. I think that for both interventions, you see that the first 3 months are going to be critical for that protection. And so I do want to share one other new piece of information. Everybody's very excited about nirsevimab because we started using it as October, when RSV season was already happening. But the NVSN again contributed to very important information. I'm proud to say both Houston and Pittsburgh are part of this data. So this is really great because it was a lot of work, but it was an early look at the effectiveness of nirsevimab against RSV-associated hospitalization. And again, real world data, as we say, you see how children here were looked at from October to end of February of 2024, and they had to have nirsevimab at least 7 days prior to having a diagnosis of RSV. And this is focused on hospitalization cases, right? They also excluded children that had whose mothers had been vaccinated, or if you did not have a conclusive RSV result. So you see about 700 children in these 4 sites met criteria. And I think that, of course, first time, this is a transition year, as I would call it, right? So we started late. We were having a lot of implementation challenges. Yet nevertheless, we gave it to, according to the CDC, about 40% of the birth cohort of children last year. But a lot of these, as you can see, were high-risk children. Makes sense. About 46% were high risk, so that's what's significant. There was no difference in the frequency of receipt in terms of preterm status or insurance type, which is great. So there was good distribution. And you can see here that from administration of nirsevimab to the onset of the illness, the median was 45 days, but even as early as 7 days, you could have already symptoms, right? So I don't know if you call these breakthrough, but there's definitely not 100% protection. You can still have infection and you can have RSV detection after nirsevimab. But when you look at the effectiveness that was calculated here, was great, 90%. So in real world, at least 45 days, remember, this is not the whole season, and also not the whole period of protection, 45 days, it was 90%. This is very promising, although it's probably overestimating, because we look at the 150 days, and when we look at the full season, it's probably going to go back to maybe 80, 85% is what I would think based on the clinical trials. But first data is coming along, and it's really exciting. All right, let me switch briefly to maternal vaccines, because I want to tell you, in terms of why we have vaccine for pregnant women and these monoclonal antibodies, it's based on the work that has been done to actually find targets in the virus that would be susceptible to monoclonal antibodies. So a lot of the vaccines in the 1960s didn't work because we were not targeting the right conformation of the F protein. So a lot of you have seen this data presented, I'm sure, that through the work of Barney Graham and Jason McClellan, the structure of the F protein was elucidated. And so here you have what we call the prefusion F protein, which is a very unstable conformation of the F protein. It's there before the virus enters the respiratory cells and infects them, because after it does that, it changes and it looks like this. So the key is that these epitopes, these target sites, are going to be changing. And in the prefusion, which is now able to be stabilized, this target site 0 is where if you develop antibodies to that, you have the highest neutralizing activity. And nirsevimab is actually targeting this site 0. So it's should be a very, very potent, monoclonal antibody. Palivizumab, remember, it works, and we had it before we understood this pre and post fusion structure. It actually targets site 2, And you see that it's present in both the pre and the post fusion. So unbeknown to people developing, it actually was targeting both. So it works really nicely. And there's clesrovimab, which I had on the slide, which targets the site 4. It also is present in both. So this is another monoclonal antibody that is undergoing phase 3 trials right now that could become available, and we should have it. And last point to make is that now that this is stabilized, the vaccines are made so that you can target the pre-fusion protein. And you see how you have a polyclonal response. So with vaccines, you have antibodies to all of these. And that is why, potentially an advantage in terms of lower risk of being susceptible to these mutations, so that even if you have a mutation that makes one of the epitope change, the virus, could still be susceptible to antibodies developed by vaccination. All right, so it's been a long trajectory with maternal vaccines. This is because, again, this is the first time we actually have a vaccine that went through a pathway of approval for a pregnancy indication. All of the other vaccines we give to pregnant people, tetanus vaccine, flu vaccine, Tdap vaccine even, were vaccines that were already available for non-pregnant individuals that we use in pregnant women, sometimes, most of the times, based on risk benefits, so risk of the disease versus risk of the vaccine, and saying, no, we really should give it to the pregnant people, just like we did for COVID. But for RSV, pregnant women don't necessarily have a whole lot of RSV disease. We did a study in Houston, and outpatients, so women coming to their prenatal care. And we found that when they had respiratory symptoms, about 10% had actually RSV. But OBs usually don't test for it, or, it's a milder illness. And so there's no need to test, but it could be, there's some case reports of serious disease. But the point here is that the main burden of disease is for infants. So it's really a pregnancy indication, but for the infant's benefit. We also know, as we have said, that we all get infected from RSV by age 2. And so by time of childbearing age, all women are likely to have antibodies. And so a vaccination is really a booster. And that way it has a good chance to work because it's going to increase these antibodies. Ideally, from what we know about pregnancy, we want at least 1 dose only of vaccine given at an optimal time to give enough antibody to the baby, and we'll go back to that, and possibly one that is not very reactogenic. And one additional advantage in addition to serum is that you can have breast milk antibodies as well. So here's the pathway. We have done this for a long time, at least since the 80s and 90s, with group B strep vaccines and RSV as well. You have to have preclinical developmental toxicity studies to make sure that there's nothing obvious there. You have to have phase 1, 2 clinical trials in non-pregnant individuals. And then after that, if the vaccine shows promise, then you can go to phase 2 and then phase 3 clinical trials in pregnancy, followed by post-authorization safety. There have been a total of 7 studies of RSV vaccine in pregnancy. That's it. Only 7. And you see that 7 because these 3 had a phase 2 and phase 3. This one, which is the one I did many years ago, was the PFP2 vaccine that I mentioned to you before. Sadly, again, this vaccine was not immunogenic enough. Fortunately, we were able to demonstrate it did not cause enhanced disease in the babies, but it was not able to produce sufficient neutralizing antibodies. So that was dropped. And then I'll talk to you about what we have learned from these, the Novavax trial, which was one that really set the stage for demonstrating that you can have a phase 3 study globally for a maternal vaccine. The GSK trial that was stopped because of safety concerns, and then the Pfizer vaccine, which is approved. I'll just show you here very briefly our study of PFP2 vaccine, who was 35 women, very small. We vaccinated late in the 30 to 34 week gestation. And, although we did measure binding antibodies, only 10% had that neutralizing antibody. Moms who were vaccinated had higher titers. Again, we don't have a correlate. And there was definitely a concern for potentially, enhanced disease because there were not enough neutralizing antibodies passed to the baby. So we followed these babies for 2 years. We tested for RSV every week if they had symptoms, and we demonstrated that they didn't have. So this is just to make the point that through maternal immunization, it's very unlikely, especially with the current vaccines, that you're going to have enhanced disease. It's almost a non-issue anymore. The Novavax trial, as you can see here, was very large, and it looked at about 4,600 women randomized 2-to-1 to receive vaccine or placebo. Now a little bit earlier in gestation, so starting at 28 weeks up to 36 weeks of gestation, and it was global. So I think there were about 18 countries represented and many sites throughout the world. And one of the important findings is that there's a hierarchy of efficacy depending on the severity of disease. So clearly, these vaccines or these antibodies generated by maternal immunization are not going to be sterilizing, right? So you can still have infections, but if you look at the most severe outcomes, like the primary endpoint here was RSV positive lower respiratory tract illness with saturations less than 95%, or our LRTI hospitalization or severe hypoxemia, which is less than 92% SATs, you have an increased efficacy that is accumulating over time. Unfortunately, this efficacy primary endpoint here did not meet the pre-specified statistical criteria, and so this vaccine was not able to be licensed, but it actually met the criteria of preventing hospitalization and the most severe outcomes, right? So it was a proof of concept, and to me, the most important message here was that it was not discouraging enough for others to continue the development of the vaccine. But you might not be aware that there are other things we learned. So all-cause pneumonia, right? We mentioned how important that is, especially globally. Having a maternal vaccine, this is the Novavax trial, studied in LMICs, low middle income countries, also allowed to see that there was a incremental protection against the severe outcomes, including all-cause pneumonia. So not looking just specifically at RSV, about a 50% reduction in all-cause pneumonia. So if you think about that, the impact that this intervention could have globally is quite significant. The other piece of information is about those antibodies, and I'll show you some for the current vaccine in a moment, but this was the Novavax vaccine immune responses in the phase 2 trial that they did. And what they measured there was what we call then the palivizumab competitive antibodies, right? So antibodies that work similar to palivizumab. And you see here, this is the mothers on the left, and those who were vaccinated compared to those who received placebo in terms of antibody titers, very, very immunogenic vaccine. And these are neutralizing antibodies. This is after 14 days at the time of delivery and even persisted in the mom for about 6 months. In the baby, as expected, because the placenta does an amazing job. It has an active Fc receptor and a pump mechanism that makes all the antibody on the maternal side go to the baby. Babies have at birth even higher concentrations of antibody than the mothers. And you see that the half-life of this IgG has been identified, has been about 49 days in this study. So you will see a drop over time. And this is the same that we see with flu, with pertussis, with other vaccines tested in pregnancy, that unfortunately, again, you see that here's the 90-day time point. By 90 days, there's going to be quite a bit lower antibody concentration. Still much higher than if not vaccinated, but even lasting, you see 120, 150, and even 180 days. So by 6 months, you kind of level out. And the point here is that the efficacy of these antibodies and the maternal vaccination is going to be dependent on that antibody concentration. So you will see that it drops over time. One other piece of information that we learned from the Novavax study is that the timing of administration is important. So they compare gestational age at immunization, and if the vaccine was given less than 33 weeks of gestation or more than 33 weeks of gestation, and you see how both the transfer of antibodies from the mom to the baby, so transplacental, and the efficacy of the vaccine was much higher if it was given before 33 weeks. So that's important. Not just magically because of gestational age. I mean, there's the issue of the size of the placenta, but there's also the issue of the time that you need from vaccination to delivery to have enough antibody transfer, because it's going to continue and it exponentially increases as you get close to delivery. So they show that too, that if the interval from immunization to delivery was more than 30 days compared to less, so 14 to 30 days, again, the transfer and even the efficacy was significantly higher. So that's a big learning from them, and again, consistent with what we know. And finally, the potential for breast milk immunity. So the current vaccine, the Pfizer vaccine, did not collect in their clinical trials breast milk, sadly, but the Novavax study did. And here you see, this is Julie Shakib from Utah, and she showed this at one of the AIDSOG meetings. When you look at RSV F protein IgA, IgG, or neutralization activity in the breast milk, you see that all of the bright colors is the vaccinated group compared to the dark bars. There's always higher activity in the vaccinated group. So the potential for protection from maternal breast milk is there. All right, take you to the current study because I think we have a couple of things to talk about. So phase 2 clinical trial of the current bivalent perfusion F vaccine that is now licensed demonstrated that you needed a simple dose of 120 micrograms without adjuvant. And if you look at, this is a vaccinated group, 120 with and without adjuvant, 240 with and without adjuvant versus placebo. For both RSV A and B, which are here in colors, in the mothers and in the babies, you had very high immune responses with high antibody titers. This is great. This is the dose that was selected for the phase 3 trial and the one that we use now. But the phase 2 trial also provided this piece of information going back to the immunity, because people have been asking about that. Remember, this vaccine was approved based on efficacy, not on a correlate of protection, because we don't have one. But if we did have an idea, maybe that here what they did is compare this with that palivizumab competing antibody. And the reference here is the titer of palivizumab antibodies that were protective in the majority of children who received it. And you see that in this study, the phase 2B, if the mothers were vaccinated and the infants here were followed over time, they had much higher, significantly higher concentrations of antibody, not just in the first 2 to 4 months compared to unvaccinated infants of unvaccinated mothers, but even up to 6 months, which is quite interesting, right? In terms of the half-life. So the higher you have the titer at birth, the longer the duration of protection will be. So that is known, at least this data is there. Then the phase 3 trial, I'll just mention a little bit of the efficacy, and we'll have to point out the risk effect that was seen. So the phase 3 trial, 18 countries, 1-to-1 randomization, now going down to 24 to 36 weeks. That's what the trial looked at. One single dose of that 120 microgram without adjuvant was given in pregnancy. And you see that 2 primary co-endpoints were here. One was just RSV-associated LRTI, and the other severe RSV-associated LRTI. And they also looked at those specific time points. So here's the paper, the initial publication in 2022, where the data show that in, again, about 3,500 women who were vaccinated versus a placebo control, you had at those 90 days about an 82% efficacy against RSV confirmed severe LRTI. This is defined with the most severe definition, which is less than 93% saturations, hospitalization, NICU admission, and so on. Yes, you have mostly a lot of effect in the first month. You start seeing some cases here, but the majority of the effect is in those first 90 days. The surprising finding was that it lasted all the way to the 150, similar to the nirsevimab, and even to 180 days at a good level. I don't know if you've seen this, but the final data, so the final analysis was just presented at ResVinet, which was a meeting in India. And this is now looking through 12 months of age, because these babies were followed for a year, and looking at the final data set. And so you see that, again, the final data is still about 82% in the first 90 days of efficacy, lasting about 70% to 6 months of life, and then some protection that even lasts into the second half of the first year, so 6 months to 12 years in these babies, which is nice to see, and it's mostly driven, again, by those first 6 months efficacy. So the point here is that you have the highest effect when you need it the most with the maternal vaccine. Safety, let's talk about that briefly. I'll show you just a couple of things. In general, in the clinical trial, the vaccine was very well tolerated. No difference in adverse events, and mothers did not have fevers, they didn't have any concerns. The issue was this special interest, which was the event of prematurity. And so the event of prematurity here is shown as an event of special interest in the mothers. And here you have serious adverse events. And you see a differential in numbers where you have prematurity here in 5.7% of the vaccinated group versus 4.7 in the placebo. Also similar differential in the low birth weight related to that. And that resulted in a relative risk of about 1.2. Now, not statistically significant, overlapping confidence intervals, and way below the background rates of prematurity everywhere where these studies were conducted. The issue was that I mentioned before, the GSK vaccine, which was being trialed at about the same time, this is during the pandemic, was actually halted, right, because of this same signal, which was preterm birth. In this case, you see it was a little bit higher, 6.8% versus 4.9% with a relative risk of 1.38. But the main problem, and so this actually was statistically significant, the difference here. But the main problem was that these were much younger preterm babies. And so the neonatal death signal was also present, which was associated with prematurity and with a relative risk of 2. This imbalance was mostly seen in low and middle income countries for both studies and in about the same period of time, which you can see here is April to December 2021, which was, if you recall, Delta period, the worst time for pregnancy outcomes. And the reason for this remains unclear, but you might have seen, this is just a quick update, the RSV GSK data was just published. I hope you can see it. I know it's very small, just 2 weeks ago. And what some differences from the Pfizer trial is that they did have more very preterm infants, so very, very, less than 32 weeks, and that was a higher risk there. That it was mostly in low and middle income countries with 1.5 relative risk. And the other thing they saw is that, just looking at gestational age, there was no difference. Having COVID in the mother during pregnancy was not different. But having received other vaccines, there was a difference, but mostly in low and middle income countries. And so maybe this was more of an effect of the regionality or geographically than that. So the bottom line is that there was a signal, and that is now needing to be evaluated. I'll show you briefly the data from the Pfizer study, because this was also shared as a final analysis at ResVinet. You see here the terms, babies were the majority with normal birth weight. And you see that most of the preemies were actually more than 34 weeks, not very preterm. So that's one difference. The other difference is that the mortality was not higher. You have in the placebo, in the placebo group, a higher number of cases of deaths compared to the vaccine group. And that was true also for the preterm. So in this study, there was no neonatal death associated with the prematurity. And then finally, you see here how by country, it was mostly driven by cases in South Africa. Here in the US, that was not a high risk. In other countries, it was not a high risk. So it's interesting because, of course, this was taken very seriously. And you see that another point was the issue of when it happens, temporality. The majority of preterms occurred more than 7 days or more than 30 days after vaccination. So there was no temporality associated. And so the point here is that we have now recommendations in the US that restrict the administration of the vaccine between 32 and 36 weeks because of this potential risk, although there is no consensus in the ACIP working group regarding the clinical impact of this, because there were other imbalances, for example, low birth weight and jaundice that did not really result in any problems. But there's going to be post-marketing surveillance that occurs. I'll just say briefly, because I would like to finish in a minute or two so that we can have time for questions, that, the recommendations are very clear in the US. It's a great benefit that we have both options, both vaccine and nirsevimab, and that either one can be used to prevent RSV in babies. Both are considered safe and effective. And remember, both give you passive immunity. And the duration is going to be dependent on that half-life of the antibody. And so I think that although you don't need it, you don't need to have both interventions in most babies, it's going to be important to try to utilize both as best as we can. The uptake of maternal vaccine, according to CDC, I've heard was only about 16, 17% this season. So not great, but again, it's a transition year. And then big shout out to our ACOG and other obstetric colleagues who have been great partners and advocates to vaccinate pregnant women. I think that for us in pediatrics, the main issue is that we do have the option to have an incremental benefit when we have monoclonal antibodies available, because obviously not all women are going to be vaccinated, not all babies are going to have access, and we've had issues with implementation. But it's a safety net so that if vaccine is not given to pregnant women, we can give this monoclonal antibody to babies, even in cases where, you know, there's been a proper vaccination and enough time from vaccination to delivery. You see that if there is any concern that the mother did not respond to the vaccine, or that there is pooling of antibodies from the baby from ECMO or other increased risk, you could still go ahead and give the monoclonal antibody. So I think that's great. But the issue has been implementation. And I'll just briefly say, we still need to work on this because the maternal schedule is becoming very crowded. We have 4 vaccines. 2 of them are mostly for the mom, the flu and the COVID, although I could argue that babies need the COVID antibodies from the maternal vaccine too. They're seasonal vaccines. Flu and COVID can be given at any time in pregnancy, but they're seasonal. Tdap and RSV restricted. And so the challenges here are going to be who's going to discuss this with mom, you know, mostly the OBs, how are we going to implement these in our practices and so on, and documentation. And then the last point is about post-approval safety. So critical to have more data regarding these signals so that we can really try to increase that window of administration, because we have to, you know, I'm worried about the fact that we won't have enough impact if we have restricted administration period, because as we have seen, I'll just say as a final summary here, that while we're boosting antibodies and we're trying to prevent severe disease, the efficacy of the maternal vaccine is going to depend on a number of things. Those titers at birth, given the vaccine at the proper time, which is likely before 33 weeks, the right time between vaccination and delivery, which should be at least 2 weeks, if not more, that durability and half-life, and then maternal health and a number of other factors, co-administration of vaccines, and et cetera. But right now, the risk-benefit is very favorable. And I'll leave you with some questions. This is my last slide, that the journey is not over because now we have a different set of challenge, a different bar to jump over, and that we have not just administration and implementation challenges, but we need to look at efficacy of both one versus the other, again, comparing at birth versus maternal vaccine, real setting efficacy and looking at different factors. Maternal HIV, for example, is being studied. Are babies going to have more severe disease? Probably not. I don't think that should be an issue of enhanced disease. Should we give the vaccine at every pregnancy? Well, just like Tdap, it could make sense, but we still need to learn more about the safety and about the durability of antibodies. Breast milk, you know, is it really going to be an advantage? And then can we crack the code for a correlate? That's going to be the last frontier. Thank you all so much. I hope we do have a little bit of time for questions. Thank you.